to do this afternoon, it's a rather large topic actually, because this is our bread and butter, what we're going to talk. So I'm just going to talk about procedures which we commonly do and what kind of patients might benefit from these procedures. So that's what we're going to do, and we're going to look at very selected topics like how we're going to manage the spinal pains, which is a common thing which we deal with. How we kind of manage the joint pains, particularly the shoulder joint and the knee pains from an interventional pain perspective, and also a brief look at the most common musculoskeletal condition, which is the myofascial pain. So 80% of pains are myofascial. So we're going to look at it, and we also briefly look at the different elements with that. So next, it's a rather large presentation, and it's going to go a little bit faster. So if you want me to slow down, just tell me so. Okay, next slide, please. Okay, so this is the story with the spinal pain. So all the interventions, what we do is all on a little bit of a shaky grounds, actually. There are very few interventions, particularly injections when it comes to the spine, which has got decent quality evidence, something which you can prescribe for your patients. Now, it doesn't necessarily I don't want to necessarily limit myself to cancer-related musculoskeletal pain, because cancer pain, yes, okay, you also have musculoskeletal pains in addition to the usual cancer pain. So it's a very, very high incidence, the spinal pain, but there is paucity of evidence-based guidelines. Okay, next slide, please. Particularly in the spinal pain, it is the interview, the way what we speak to the patient gives us much more information than actually kind of examining them or imaging the patient, and is the most important part of spinal pain assessment. And so speaking to the person in pain gives us a lot of information with regards to where it's radiating, what makes it better, what makes it worse, and all those things. Next slide, please. Right. So once we have done that, the most important thing when it comes to spinal pain is to pick up what we call the red flags. Okay, so this is a list of conditions. So if there is a recent history of trauma, there is a history of rheumatoid arthritis, or if they have fever or neck stiffness, there's a history of immunosuppression, they have a history of fever, weight loss, they have upper motor neuron pathology, all these things. When they come with spinal pain, this is the first kind of set of questions we ask, because we do not want to miss any life-threatening or limb-threatening problems which might arise. So that is typically cancers and infections, which tuberculous spine is extremely common in India. In fact, one of my teachings when I was training overseas is that you do not do an MRI scan of a spine till you've tried all the conservative measures and the pain doesn't settle down. I've in fact changed that practice in India because tuberculous spine is so common and rampant. So this is the red flags, what we call it. And when we talk about colored flags, there is also something called the yellow flags, which also you have to be aware of. It is a concept which was developed in New Zealand, looking at if someone's got back pain or neck pain, what would stop them from getting better, which is looking at the psychosocial factors. And that is also important. This is the biological factors, which is the red flag, which should kind of keep the alarm bells going. So next slide, please. And these are the psychosocial obstacles to recovery. So if someone thinks pain is harmful or disabling, it must be eliminated completely. If you're expecting 100% pain relief before getting back to your usual activities, then that's never going to happen. Passive attitude towards therapy, you are the doctor, you take care of me, rather than, this is my pain, I can take care of it, you help me. So that's a very important sort of thing. Extreme pain intensity. You ask someone, what is your pain score? 0 being no pain, 10 being worse pain, and if they say 100 out of 10, then that should keep your alarm bells going. It's outside the scale. And also use of alcohol and other stuff. So these are the psychological or the yellow flags, what we call it. Next slide, please. Okay, so these are the questions we ask when it comes to spinal pain. Is it acute, subacute, or chronic? Now, the definition is very arbitrary. Anything less than 3 months is subacute and acute, and anything more than 3 months is chronic. Now, you don't ask me why that is. It's just an agreed dictum. And then we want to know whether it is somatic or whether it's neurogenic, which is whether it's coming from the tissues or whether it is coming from nerve content. And are there the red flags and yellow flags? So these are the 3 main questions we need to find when it comes to spinal pain. Next slide, please. In general, if you want to examine the patient, if you look for abnormal appearances, the range of movement, and tenderness in the spine, they are non-specific overall. It indicates that there's a problem in the spine, but it does not give you the information what exactly is the problem in the spine. So this is the issue. The specificity and sensitivity of these examination findings are not very useful at all. Next slide, please. Okay. Now, physical examination, again, as I said, it's not of much use, but it is very helpful in other ways. Next slide, please. Next slide. Yeah, it provides the clinician to assess the pain behavior and fear avoidance pattern. So you touch and the patient jumps out. It means, well, there's a problem here because they might be catastrophizing. Thinking about the worst possible scenario, there might be hypervigilance, there might be rumination, there might be magnification. All those things kind of cross my mind. Next slide, please. Yeah, and provocative maneuvers, is not very good at all. So next slide, please. I mean, the reason I'm telling you all this is it's only the diagnostic injections which is going to help you. Examination doesn't give you much information with regards to what the problem is. Radiography, the MRI scans and the X-rays, again, it doesn't give you much information. So history taking gives you a lot of information. Next slide, please. Okay, so this is what helps when it comes to nerve. So if you have someone suffering from spondylitis or some what we call the non-specific back pain, they're not exactly non-specific. They might be coming from the facet joint. So image-guided medial branch nerve blocks is the most effective way, and you have a lot of sort of guidelines backing it up. So we're going to look at how we're doing the medial branch blocks. Next slide, please. Both in the neck as in the lower back. First, I will kind of quickly go through this slide. This is the usual sort of things looking at the conduction from the peripheries to the spinal cord to the brain, and from there to the from thalamus to the cortex. Here, we've just replaced the tissue with muscle discs, facets, and nerve roots. And the pain transmission is pretty much the same. You have the ascending sort of pathways taking the pain up to the cortex, and then you have the descending inhibitory pathways as well. Next slide, please. Okay, so this is a typical what looks like a spinal. This is the cross section of the lumbar spine. If you look at, can everyone see the pointer I'm using? No. Okay, I don't think I can use this pointer, but anyway, the facet joints you can see sitting in there, and there are a couple of nerves which supply the facet joints, which arise from the posterior primary rami. Each facet joint has got a dual nerve supply at the same level as well as one level above. The previous slide, please. Next slide, please. Yeah, so this is what it's looking at. So it's the medial branch which we have to block for the facet joint for the spinal pains. Next slide, please. So if you look at the next slide, if you look at the spine itself, 80% of the loading takes place within the vertebral body and the disc, and 20% of the spinal load is taken up by the facet joints. These are tiny joints in the back of the spine. There's a pair at each level, starting from the neck down to the lower back. Next slide, please. Okay, and this is a general algorithm when it comes to back pain. If you think it is nociceptive or tissue origin, you do the facet joint injections or the medial branch blocks, which is blocking the nerve which supplies the facet joint. And then if the result is positive, you go on to do what's called the radiofrequency. If it's coming from the sacroiliac joint, we do a sacroiliac joint injection. If it is coming from the disc, then there are certain interdiscal therapies. You can do a discectomy. A lot of things could be done. But if the pain is radiating or radicular in character, then we can think of doing epidurals. We can think of doing what we call the percutaneous adhesiolysis as part of intervention. Percutaneous disc decompression, which normally the orthopedic surgeons do. I think a few pain physicians do it themselves, and also other things like endoscopic adhesiolysis and implantable therapy. So this is the kind of general algorithm. So if it is coming from the tissues, you have a certain sort of injections to do. If you think it is because of nerve compression, then you have certain other sort of interventions to think about. Next slide, please. Okay, so this is what, if someone's got a facet joint pain, it doesn't mean that the pain should mostly be focused on that part of the body only. You can see the L3-4 pain. It can radiate to the buttock, to the back of the thigh, and even to the side of the calf muscle as well. And if it is L4-5, you can see it goes down up to the ankle, which means it might mimic sciatica. So this is a crucial thing to understand. If they do not have pins and needles or tingling sensation in their toes, it means that it is unlikely to be a radicular pain. in that it's not pressing the nerve. It could be the facet joint pains, it could be the sacroiliac joint pains, it could be the piriformis spasms, which kind of go down up to the ankle. So we have to be extremely careful. Not all leg pains are sciatic. It can be pain which is originating from the joints in the back of the spine. Next slide. Okay, so this is kind of having a closer look. If you look at the L3-4 facet joint, you can see that there are two nerve endings there supplying that facet joint. Next slide, please. So this is a cartoon, a line diagram, and this kind of looks at it. You can see there on the second image to your right, it is marked X. Now that is a branch from the posterior primary rami, and if you trace that branch, you can see it is supplying the facet joint over there. Now our aim is to actually block that nerve. Next slide, please. Okay, so this is what it looks like on the Okay, yeah, so this is what it looks like on the x-rays. It looks like, you can see, it looks like a tiny Scotty dog on the image, and all we have to do is look at the eye of the Scotty dog and go at the top of the eye of the Scotty dog. Next slide, please. Okay, so this is how we position the patient. They go prone. You have a ipsilateral contralateral oblique and the caudal capsular orientation. Next slide, please. Okay, and this is a line diagram, a cartoon. So the needle goes in, and that's where we want to block the medial branch. Next slide, please. Okay, so this is again, the P stands for the pedicle which of the thing. The TP is the transverse process. The IAP is the inferior articulating process, and the SAP is the superior articulating process. And the facet joint injection is the junction between the transverse process and the superior articulating process. Next slide, please. And this is the cervical facet. You can look at the neck also. You have the same sort of joints. Again, it's a dual nerve supply. And you can see the injections of the neck. You can, on the right side, you can see the needles being positioned under X-ray control and trying to block the nerves. Next slide, please. Okay, now we're going to look at the sacroiliac joints. So this is the final joint is the joint between the spine and the hip bone. There's always some tenderness when you palpate it, and the joint pain also radiates down to the buttock and the thigh, but not below the knee. And most of the times it gets better with some heat application, anti-inflammatories, and physical therapy. But on occasions it doesn't respond, and we end up doing what's called the sacroiliac joint injection. Next slide, please. We'll first look at next slide, please. Okay, so this is what it is. If you look at the back, most of the pain is focused around the upper part of the buttock, and some pain in the back of the thigh. And there is also there is pain radiating the front. So sacroiliac joint pain, you can also have groin pain and pain going down the legs. Next slide, please. Okay, and this is what the injection looks like. So you can see the sacroiliac joint clearly in the X-rays, and you can see the needle going into the joint itself. And in the second, we put some contrast, and you can see the contrast spreading in the joint, and then we inject some local anesthesia, probably with some steroids as well, and you can get a good relief. But if the pain comes back, then what we do is we do what's called the lateral branch blocks of the sacroiliac joint, and we also heat up the nerve with the radiofrequency lesion so that it gives long-term benefit. Next slide, please. I think the next slide talks about the radiofrequency. And this is how we do the radiofrequency lesioning of the sacroiliac joint. You could see the needle positioned along the different sort of levels close to the sacral foramen, and more the line diagram on the right side has much more information. So we kind of do multiple lesions around the sacral foramen, so that the nerve supply in the sacroiliac joint is stunned and they get good benefit. Nowadays we get one long needle which can do all these lesions in a single sort of sitting. That's also possible. Next slide, please. And this is what the radiofrequency treatment is. That basically we are heating up the tissues. We send the radiofrequency waves, which heats up the tissues, and that heat is recorded by the radiofrequency cannula. Next slide, please. There's a little bit of physics involved. I think I'll just put it up here so that people can go through the slides at a later point when you have. So basically, we heat it up to 60 degrees plus for about 90 seconds, so that it is an irreversible lesion. Next slide, please. Okay, and you can see there's a bit of physics there. I think, Sunil, do we share all these slides with the participants? Yeah, okay, that's fine. Okay, so you can have a look at it. There's a lot of physics in there. I don't want to kind of bring in too much of that. Next slide, please. Okay, and for lumbar radiculopathy, this is the disc which is pressing on the nerve, or whether there is a tiny sort of annular tear in the disc which is causing chemical neuritis, causing a lot of sciatica sort of pain. So in radiculopathy, we look at tingling paresthesia in the affected nerve root. So if someone talks about sciatica, it is not just pain going down the leg. It is pain going down the leg, which is sharp shooting in character, and you have these paresthesias in the feet and the toes. So it's something which we have to look for. You look for weakness and sensation, SLR, MRI, all sorts of things. Now I'm going to talk about epidural injections. Next slide, please. So this is what we do. It's called the transforaminal epidural injection. You could see the needle is positioned just underneath the pedicle on the left side, and then we've injected contrast, and the contrast is spread in the epidural space and is also tracking the nerve root. And if there is a single level disc which is pressing on the nerve, causing a sharp shooting pain going down the leg with paresthesias, this seems to work well. Now, if you think about the disc as a cause and causing this radiculopathy, the crucial point to understand is 3 months later, even if you don't do anything at all, with no medical treatment whatsoever, 80% of these patients get better. Okay, that's the natural history of the disease. Now, we do this in the initial stages just to buy some time so that they are kind of reasonably pain-free for a few months, actually. So it doesn't necessarily work fantastically well in long-standing sciatica, but in acute sciatica, it works extremely well. And we do the same in the neck as well, the cervical sort of epidural injections. Next slide, please. Okay, so we quickly move on to the joint issues. We're going to look at the two joints. That's about the spinal pain. We kind of talked about the cervical facet injections, the lumbar sort of facet medial branch blocks, the sacroiliac joint injections. We looked at the epidural injections, the transforaminal epidural injections. We're going to look at the knee pain, and I'll quickly show what we do because it affects, osteoarthritis of the knee affects the synovial joints, and a lot of changes happening in there in terms of the overgrowth of the subchondral and the marginal bone. Next slide, please. And a lot of treatments are there, so you just need to differentiate whether it's any other sort of issue, particularly in the hip. You want to kind of rule out things like avascular necrosis and things like that, which could, for which the treatment could be completely different. And so you need to rule out a differential diagnosis. Next slide, please. And there is a lot of treatment options there. You educate the patient, you talk about weight loss, social support intervention, exercises, orthotics, footwear, and this is the typical of the American Orthopedic Association sort of recommendation for managing osteoarthritis. Next slide, please. So a lot of things could be done. You're looking at topical drugs, and what I want you to focus is on the third from bottom, which is intra-articular treatment of corticosteroids and hyaluronons, which is hyaluronic acid. Now the thing is that corticosteroids you keep injecting intra-articularly. Even the orthopedic surgeon do not recommend injecting more than once or twice because these are particulate steroids which goes and digs into the cartilage and make things even worse as time goes by. And injecting these viscous sort of supplements like hyaluronic acid, again, it kind of works for 4 to 6 months. The pain comes back. Pretty expensive business as well to get those. I think they're about 6,000-7,000 a shot. Next slide, please. So what we do is something called the genicular nerve blocks. Now, this is something which has been recently reported. It's only been in the literature for about, following an RCT, randomized controlled trial, it's been in the literature for about 6-7 years, actually, and we've been doing quite a lot of these, which is blocking the nerve which supplies the knee joint. Now, there are more than a dozen nerves which supply the knee joint, and what we are interested in is just the 3 nerves, the supramedial, the inframedial, and the supralateral genicular nerves. And in that image, you're looking at the supramedial and the inframedial genicular nerves. Next slide, please. It's just a cross section. I think the next slide will show you the supralateral and the supramedial, so infralateral genicular nerves. Next slide, please. And we'll have a look at the dissection slide as well. This is looking at the genicular arteries and how close to the genicular arteries the nerves lie about. This is a dissection slide. Next slide, please. And we do it under both fluoroscopy and ultrasound. Now, my expertise or specialty is doing it under fluoroscopy, and it's my colleague Dr. Sendel who does it under ultrasound. So I tend to do it under fluoroscopy, and that's what you're looking at. So you're looking at the knee joint, the junction of the condyle and the shaft on both sides. We go in and also in the tibia on the medial side. We look at it laterally confirm the depth of the needle, and all we do is inject some local anesthesia, come out and see how the pain works. Now, sometimes the injection, not sometimes, on many occasions, we see that these pain relief lasts for a good 6 to 9 months, and all they need is repeat injections, because these patients may not be fit for surgery, may not want surgery, or maybe radiologically their needs are not kind of bad enough for surgery. So they don't have much options apart from taking anti-inflammatories and giving more business to the nephrologist. So I think we can help them out by doing some genital nerve blocks. Next slide, please. So we're going to look at the shoulder as well, looking at the short axis as well as the long axis. These are the common conditions what we treat. Looking at bicipital tendonitis is extremely common. And the conditions, you look at frozen shoulder, bicipital tendonitis, citroscapular tendonitis. These are the common ones what we do. So this is looking at under the ultrasound. This is not a procedure which I do, so I borrowed the slides from my friend and colleague. Next slide, please. And if you look at the long axis, this is what the biceps tendon looks like. So we go in and we do image-guided injections for the shoulder joint. Okay, next slide, please. So the shoulder joint, I think the examination is crucial. You look for internal external rotation, you look for abduction, and then you make the diagnosis, what exactly the problem is, and then do the injection. So subscapularis tendon, again, it's like a rotator cuff problem. Next slide, please. We do the subscapularis injections. There you can see that's a problem with the tendon, and we do the injections. Next slide, please. Supraspinatus, again, it's extremely common. You ask the patient to take the arm back, like trying to sort of do the bra or trying to kind of scratch your back, and the pain is reproduced. And we look the supraspinatus tendon under ultrasound, and we could inject closer to the tendon. Next slide, please. This kind of just looking at different axes, that's all for your own sort of understanding. I myself, I'm not an expert in the ultrasound, so I can't give you much information if someone has doubts in the end. Next slide, please. And this is the glenohumeral rhesus, where you can inject medications if you want to kind of treat them for frozen shoulder, particularly common in diabetics, and it can happen in anyone in patients with cancer too. Next slide, please. And these are the AC joint problem, the acroclavicular joint. Again, it's a common problem which is missed, and unless you specifically focus your MRI scan on the AC joint and speak to the radiologist to look for AC joint problems, it is very, very commonly missed in shoulder scans. Next slide, please. And this again is a suprascapular nerve block. It is a reasonably straightforward injection. We do it both under fluoroscopy and under ultrasound. I think more and more I'm moving towards getting it referred to my friend who does it under ultrasound, because it's much simpler getting it done that way. And you can see the suprascapular nerve supplies the shoulder, and for any sort of shoulder pains, if you're unsure about your examination findings and if you're unsure which tendon to inject, then this is a safe option to do suprascapular nerve block, and then you can do a pulse radiofrequency of the suprascapular nerve. Next slide, please. I can show the thing under the, see, that's the looking at the suprascapular from above, and that's the ultrasound sort of image to your right side. Is just underneath the supraspinatus. You can see the notch, and if you add the color on, you can see the suprascapular artery, and it lies very, very close to the suprascapular nerve. So you can go in and inject local anesthesia and then come out, and if the pain reduces, you can either ask them to come back to get a pulse radiofrequency done, or sometimes if you're lucky, then the pain doesn't come back at all. Next slide, please. So we looked at these things and the two joints, and quickly going through these myofascial trigger points as well as fibromyalgia. Now, it is not that we don't do that many interventions for the trigger points apart from trigger point injections, but just to round up things when it comes, because this is the commonest problem which we see in our practice, whether it's cancer related or whether it's non-cancer related. So we have to look for the myofascial trigger points. The commonest muscles which we see in my own practice is the rhomboids and the trapezius. These are the two common muscles where we see the myofascial trigger points. Next slide, please. And obviously it's going to be tender because the trigger point, and sometimes you can feel a taut band when you roll your finger around that muscle, and there's some pseudo weakness. If you ask them to lift their hand, if they can't, because of pain, because of nerve compression weakness, and you press that point, and the pain radiates is called the zone of reference. There's a referred pain from that particular point. Next slide, please. So we have a lot of interventions we can do. Mostly it's needling. Now the thing is, you can see in the brackets saline, local anesthesia, all sorts of things. Now all it means is we don't really understand what helps in these myofascial trigger points. Whether the very act of needle going into the trigger, or whether it is actually injecting. See, you can inject saline, the pain goes away. You can inject local anesthesia, the pain goes away. It means it's not the medicine what you inject. It's probably the fact that you're needling that trigger point is what is helping them. And so we do a lot of things, interventions and laser therapy. We have a very, very good physiotherapy service here who kind of extremely well trained in osteopathy and manual therapies. These are strong support for such interventions. Some moderate evidence for all the physiotherapy modalities, the interferential current and the galvanic stimulation and things like that. Next slide, please. Okay, and currently unproven, Botox injections and treating trigger points with anti-inflammatories and ultrasound, it doesn't help. Or it is not proven yet. Next slide, please. Which is fibromyalgia, and fibromyalgia we kind of come across very often. 9 out of 10 fibromyalgia sufferers are women. It's much more common, particularly in middle age, and it doesn't have a pathognomonic test to confirm it. It is mostly from the clinical examination and diagnosis. Obviously, you have to rule out certain rheumatology conditions, so you check for certain things like rheumatoid factor and things. And if it is negative and it's whole body pain with generalized tiredness, sense of stiffness and swelling, and all other sort of things excluded, then you make the diagnosis of fibromyalgia. Now, the thing is, we like to think it is not that common in India, but it's very, very common. We see at least 2 to 3 patients every week with fibromyalgia. So these are all undiagnosed pains, and this treatment is simple, but it is not as effective as you would like it to. Next slide, please. Okay, strongly supported by evidence. It's the gabapentinoids, the psychological treatments, and the exercises. This is all it helps actually. And anything else is a little bit dodgy when it comes to fibromyalgia. None of the interventions work. None of the injections help in fibromyalgia. Next slide, please. Currently unproven. There is a long list, including things like Qigong and tender point injections. It doesn't help at all. Paracetamol doesn't help fibromyalgia. You might think the thing is that it's a misnomer actually. We call it fibromyalgia, and we assume that it is coming from the fibrous tissue and the muscle, but it is not so. The current understanding is the brain and the spinal cord are sensitized because of the chemical imbalance. And what is touch and what is pressure for you and me is interpreted as pain by these patients. So it's more like a central sensitized state where it is only pharmacological management. Next, please. Okay, and these are things which you should not do. It is refuted by evidence, which is putting them on anxiolytics, benzodiazepines and cyclopram and steroids and neuroleptics and anti-inflammatories. It is refuted by evidence. There are things that we know it certainly works. There are things that we don't know for certain whether it works or not. And there are things we know for certain it doesn't work. And these are the things which we are certain that it doesn't help fibromyalgia. Okay, next slide, please. Okay, so that's about it. This is our NGO. We do a lot of teaching and training activities across. I think we'll be coming up with a big project in Telangana, starting in a couple of months, reaching out to a lot of people. And next slide, please. And that's the Twitter handle, Pain Free India. You can see, I keep updating it every day. There are a lot of pain-related research information being tweeted there. So that's about it. Thanks a lot. I know it's a rather longish presentation, but I'd like to cover these are the commonest interventions, what we do. I think the one thing which I probably missed is the caudal epidural injection. So that's quite easy to do. Maybe we'll talk about it. I'm talking on cervical cancer intervention. Include the slide there. So I think that's about it.
For discussion, so
anybody would like to ask any questions, Dr. Vijay?
Shall wait for the others to finish. Did you hear me?
Yes, sir.
Yes, yes, yeah. I did. Good afternoon. Good afternoon.
Hey, thank you, Vijay.
Dr. Mary.
Madam.
Vijay, that was really a comprehensive talk that you gave in such a short time. You tried to cover so much. That is a Herculean job, I must say. Anyway, what I wanted to say is about myofascial pain. Like you said, mentioned 70 to 80% of people who come have myofascial pain. And you mentioned trigger point injections. What about dry needling? Because I do quite a bit of dry needling for these patients. What is your experience regarding dry needling?
I don't,
or intramuscular stimulation or whatever it's called?
I don't do them, madam, but the thinking is, I mean, it is not what we inject. It is the very act that the needle goes in which seems to be of use, actually. Yeah, so exactly. If you look at it that way, I think dry needling works or is as effective as injecting steroids or injecting local anesthesia in there. I think for me it works, but I think we still need to build up a body of evidence to, you know, say certainly that this is what we have to. But a lot of my own sort of friends and colleagues who trained with me, they do dry needling and they keep reporting good results. I haven't tried it myself, actually, so I can't really comment. But I don't have any opinion against it.
In fact, they're doing ultrasound guided dry needling also, you know. Yes, yes. That's also coming up in a big way. So yes. I do a lot of dry needling that way.
Yes, yes. Nice to know.
Can I ask one more question?
Yes, please, ma'am.
Okay. See, we were talking about the physical aspects. I feel pain is a biopsychosocial phenomenon, particularly when it comes to chronic pain. So we need to address, pallium and all, we have to address the psychological and social aspects also. So that also needs to be an integral part of the pain management, I feel, particularly when it comes to chronic. A biopsychosocial rehabilitation program. Something like that we have to do, particularly when it gets chronic and it becomes a chronic pain syndrome rather than just chronic pain.
Yes, yes. I agree with you completely, ma'am, because particularly in these musculoskeletal pains, if they're not settling down within a few months, we have a long, particularly there's a lot of research being done in spinal pains, the low back pain and neck pain, looking at the psychological issues which might manifest. They reckon the anxiety is about 40 to 50% of people who had back pain for more than 3 months suffer with anxiety. There is depression, there is catastrophizing, you know, thinking about the worst possible scenario. We have fear avoidance, we have fear of movement, kinesiophobia, they call it. As you rightly pointed out, you know, sticking a needle or just starting them on some anti-inflammatory is never going to help all these things. I believe there's always going to be some tissue damage which we can treat, and how people react to that and how they think about it and how their behaviors manifest because of this pain problem is what gives the complete pain picture. Because nociception is the same for everyone, pain is experienced differently, and we need to address those issues. And without addressing the psychological issues and the social issues, we are very rarely going to make any sort of big difference to people's lives.
Regarding osteoarthritis, is it which is more effective, corticosteroid injection alone or hyaluronidase injection?
See, people still do. I mean, there's a lot of things actually. It's typically the orthopedic surgeons who do the steroid injection, and I know my own sort of friends who are orthopedic surgeons. They wouldn't recommend more than a single shot of steroids. There is a recent, there's a study which appeared in BMJ, British Medical Journal, looking at the intra-articular steroid injections. So they were looking at how long it helps. The best result they got at 3 weeks. So it doesn't help for more than that. And the other problem with the intra-articular steroids is these are all particulate steroids. Now, if you look under the microscope, they are sharp as diamond, actually. So you put it inside into the joint, and it sits there and keeps digging into the cartilage. It actually kind of, they say it hastens up the whole process of osteoarthritis. So I think people are moving away from injecting steroids into the joint. People have started using viscosupplementation, the hyaluronic acid. That could also be done. It is slightly on the expensive side. Again, how often you repeat it. It lasts for 4 months, it lasts for 6 months, which means you have to keep repeating it thrice a year. And unlike injecting steroids where you use a finer needle, to inject hyaluronic acid, you have to use a larger needle. And every time you enter into the joint, there is always the risk of infection, bleeding. Once we understand how to inject, then we want to try all sorts of things, actually. They started injecting ozone into the joint. Obviously, it wasn't helping. You give a chance for the intervention pain medicine physicians. They inject coconut oil and diesel as well, actually. So you have to be very careful with what people propose. I think the fad or the fashion these days is to inject what's called the PRP, which is the platelet-rich plasma. So they take the blood, they spin it, and then there's a concentrated plasma, which is 3 to 8 times the normal concentration, and they keep injecting into the joints. I think for me, none of these have been proven, and it's just kind of working on hearsay. We do a lot of things, but I mean, genicular nerve blocks. Yes, it's only been there for a very short duration, but within that time, there are a lot of articles published looking at how effective it could be, and it is the biggest advantage. It's extra articular. All it needs is fine sort of, needle injections, and it seems to work pretty well. Actually.
Dr. Shyamala has a question. And Dr. Shyamala, can you ask, please?
I was just asking whether it's the same as enthesopathy and enthesitis, the fibromyalgia thing.
Madam, they're slightly different. The enthesopathies are mostly, it comes under the tendinopathy classification. And we tend to see a lot of, enthesopathies I didn't cover in this topic because we don't do that many interventions. The commonest ones, what we see is around the shoulder, the suprascapular tendon, the supraspinatus tendon, and the other common enthesopathy is what we see is the tennis elbow and the golfer's elbow, which is the lateral epicondylitis and the medial epicondylitis is very common. And one other common thing, particularly among middle-aged women and people suffering from diabetes, is the plantar fasciitis, which is quite common. These are the common sort of enthesopathies / tendinopathies, what we see. Now, our treatment protocol is almost always rehabilitation driven. It's functional vocational rehabilitation. Typically, we don't inject unless it is becoming refractory to a lot of treatment, and that includes anti-inflammatories and even the anti-inflammatory patches, which we can put people on. So it's mostly physical therapy modalities and exercises which is going to help. And sometimes, though we want to avoid, we might get pushed into doing some interventions, and in which case we inject steroids. But the platelet-rich plasma, which I was talking about earlier, if there is one condition which it has got decent evidence for us to think about it, is in the lateral epicondylitis, the tennis elbow. So there seems to be a decent body of evidence suggesting that the platelet-rich plasma helps. So yes, I think the most important thing is functional rehabilitation. That's what seems to help in the long run rather than interventions.
Could there be a paraneoplastic syndrome associated with that?
Possibly, madam, but I've been out of medicine, proper and general medicine for a long time. Possible, it's very, very possible. It's very possible.
We do find a lot of tender nodules in the sacroiliac joints of some patients.
Yes. Okay, the sacroiliac joint, there's very important distinction because we tend to see a sacroiliac joint across the lifespan. Actually, when you get it in young people, now the thing, it sets the alarm bells ringing if they have a buttock pain with isolated tenderness over the sacroiliac joint, because the first thing we have to rule out, particularly if you see a male with a sacroiliac pain, is whether it is ankylosing spondylitis. spondylitis, because the first presentation of ankylosing spondylitis is sacroiliac pain. So it becomes part of the red flag. Actually, it's pointless treating them with injections and things like that. So we still have to do a certain sort of set of investigations to rule out any rheumatological issues, and then treat it as a thing. And the sacroiliac pain, joint pain itself, it could be of two types actually. You can have arthritic changes in the joint, or you can have what's called the sacroiliac joint dysfunction, because it's a joint which is well protected by fibrous tissues, and a tiny tear either in the anterior or posterior part of the joint can cause a lot of pain actually, particularly in the younger and in the middle-aged sort of population. We tend to see a lot of what we call the sacroiliac joint dysfunction rather than joint arthritis itself. But the treatment seems to be the same. We do a sacroiliac joint injection, and for most part, if it is not inflammatory, then the pain kind of settles down kind of reasonably well, and very, very rarely do radiofrequency ablation of the sacroiliac joint. But having said that, the sacroiliac joint injections per se acts much, much better if it is an inflammatory cause. I have rheumatology friends referring patients for sacroiliac joint pain which is not responding to the usual anti-inflammatory. So we put in some steroids into the joint. That seemed to help much, much more. The results are much, much better compared to the degenerative arthritis.
Thank you.
Thank you.
You are seeing many patients with musculoskeletal problems, including cancer patients. So, of the many things that you have told, which is the most common problem that you have come across?
I mean, for us, it's the knee pain, actually. I mean, pretty much you ask every other person has knee pain. In fact, you ask me, I have knee pain myself, actually. So it's the most common thing. I mean, people are a little bit lost because typically it starts affecting when you touch your 40s and 50s, and you're not old enough to get a knee replacement. And the knee joint in the X-rays, it doesn't look bad enough to get a knee replacement. And if you do an MRI scan, there isn't much changes in terms of operative pathology like an ACL tear or a medial ligament tear. So it's basically degenerative arthritis setting in early and becoming very, very symptomatic. And people are desperate, actually, because you can't keep taking anti-inflammatories forever. So you have to have a via media. And that's where I think our interventions come in quite handy. We combine those interventions with a lot of knee exercises, focus sort of quads and hamstring sort of strengthening exercises, and that seemed to help actually. It's a common one. We see a lot of shoulders. It depends on what, the kind of referrals, because we work closely with the diabetologists, our friends, and we tend to see a lot of these enthesopathies, which ma'am was asking earlier. We see a lot of plantar fasciitis. We also tend to see quite a bit of shoulder pain because the frozen shoulder, the adhesive capsulitis, it's kind of more, it is more prevalent among people suffering from diabetes. So we see those there.
Sir, Rajagopal sir, you have been seeing many patients with cancer in addition to chronic pain. So in your experience, what are the common musculoskeletal problems that you have come across, and you have done some interventions for that in cancer patients especially?
I did not expect to be in this position, Sunil, of having to answer questions today. I was all fired up to ask questions. Well, a significant number of people do have spinal cord, root compression as a consequence of spinal secondary. Now, in the worst situation, it would be a spinal cord compression and collapse and paraplegia. But suppose we are able to arrest that, possibly with early radiotherapy, then some of them end up with some root irritation and pain caused by that. That is one of the rare situations where you go ahead and intervene, say with an epidural steroid or something, even in the presence of a spinal cord, widespread spinal cord metastasis. There is a risk that even if there is an adjacent vertebra that collapses and patient gets paraplegia, it may get attributed to our intervention, and that is something to be informed and the proper consent obtained. So that would be a significant group. The other would be simply myofascial pains. If somebody has a cancer and the pain appears anywhere, both the patient and the treating doctors immediately suspect a metastasis to that place. It's important to remember that may be nothing like that. And if somebody has a crick in the neck and they get worried about the metastasis in the cervical spine, then their muscular pain is likely to be much worse. That is something I'll remember. I think that's about it. Vijay, would you like to answer Sunil's question and add to what I said?
Vijay.
I fully agree with Dr. Rajagopal in terms. In terms of having a high index of suspicion and see whether it is the secondaries which is causing the pain. I mean, the treatment for the bone secondary, for us from an interventional perspective, there isn't much actually. I mean, you can start them on anti-inflammatories, you can give them bisphosphonates, you can do a focused radiotherapy, you can think about radiopharmaceuticals, and that's about it. And the opioids, obviously. But in terms of interventions, there is very little we can offer in terms of injections. But yes, we will have a very, very high index of.
Dr. Vijay, you are hardly audible. So can you repeat it once more?
Okay. If someone with cancer presents with a new pain, which is kind of unexplained, then there is going to be a very, very high index of suspicion that it is probably secondary unless until it is ruled out. So I will have a high index of suspicion. Now, when it comes to secondaries, particularly the bone secondaries, I mean, my experience is that I don't treat them very well in the sense that there is very little we can do actually. I mean, you have a long list of medications which you can use. You can use anti-inflammatories to treat bone secondaries pain. You can use the opioids. You can use the bisphosphonates. We can do a focused radiotherapy, particularly as a prophylactic. If you think that this is going to be an impending sort of crush fracture of the vertebra, which is going to press on the spinal cord. And you can also think in terms of radiopharmaceuticals, the samarium and the strontium, but that's about it actually. In terms of interventions, whether you can stick a needle and you can put some medication which is going to make a difference to the pain, I think it is unlikely that interventions will help, particularly in the bone secondary. It's going to be systemic treatments and focused radiotherapy.
Sunil, my question to Vijay. Vijay, in your presentation, when you were talking about fibromyalgia, I would completely agree, and you said there is no evidence really for the benefit of needling. But I have this caveat. In fibromyalgia, sometimes there can be myofascial trigger points. Would you agree? You would? Would you
yes,
agree?
sir. It is not. It is. You asked me a very relevant and practical question actually, because we think all pains are fibromyalgia. You touch everywhere, and that lady says it's painful everywhere, and there is a loss of sleep, and there is a lot of other issues. It comes like it's a bouquet of symptoms. You start kind of exploring. They might have menstrual health issues, the previous history of sexual abuse, all sorts of things. In a migraine, some sort of atopy, where they're allergic to a lot of things. So it's like a big syndrome. And in terms of treatment, I mean, if a patient comes to me and says that she's got pain in one particular part is more painful than the others, then what I would do is to treat it as fibromyalgia, which is the EULA, the European League Against Rheumatism. They have a very standard sort of a batting order when it comes to treating fibromyalgia. So you have the pregabalin or the gabapentinoids as the first line. Then you add the duloxetine, which is the SNRA, as the second line. and use tramadol as required. So these are the 3 drugs, and they talk about milnacipran and the newer drugs. But these are the 3 medications which you would normally use for fibromyalgia. So you treat them for a few weeks, maybe 3-4 weeks, and most of the times the pain comes down. It doesn't go away, but 50-60% is reduced. And then I go back and examine them again and look at any other pains which are left. So you can still have myofascial trigger points sitting within a fibromyalgia diagnosis. In those cases, if you can pinpoint where they're coming from, then you can kind of think along treating as a myofascial pain, which Dr. Mary Abraham was mentioning earlier. You can think in terms of dry needling, you can think in terms of injecting local or steroid, or just simple stretching. Physiotherapy stretching will be quite helpful. But because I mean, we can't sort of think in silos when it comes to pain. You can have fibromyalgia, you can still have myofascial pain on top of it, or you can have a predominantly myofascial trigger point, myofascial pain syndrome with an element of fibromyalgia mixed to it. And it doesn't need to be one pain or the other. It could be multiple pains together.
Please see if you would agree with this statement. Ordinarily, in fibromyalgia, for myofascial tender points, that's my word, I am using tender points, not trigger points. For myofascial tender points, there is no proof that needling can help. But occasionally, if there are trigger points, then it should be treated as a trigger point. And just because the person has fibromyalgia, it is not necessary that all needling can be avoided.
I agree with you, because I think for the audience, there are two sort of a crucial difference. One, you're talking the myofascial pain. The other one, you're talking about fibromyalgia pain. In myofascial pain, we talk in terms of trigger points. Okay. In fibromyalgia, we talk in terms of tender points. So these two are completely different sort of things. The trigger point is when you press and the pain is reproduced. It has a zone of reference. There's a taut band. You can feel it springing, all those things. Fibromyalgia, you touch everywhere. It's a chronic widespread pain. So these are two different things. Trigger points are different, tender points are different. Now, if you're going to inject the tender points, we're going to be extremely disappointed because what we get out of it is going to be pretty poor, actually. Whereas if you can identify a trigger point, which is it's a myofascial pain, and if you can do the injections, then that will kind of provide the desired benefit. So these are two different concepts, and we have to treat the tender points different from trigger points.
Vijay, when somebody says pregabalin or gabapentin is a first-line drug, my antennae go up. I would start looking for evidence, and I would check to see if the evidence is created by the manufacturer. In this case, I thought, honestly, I had not seen a systematic review. Maybe there are, it's not as if I am looking it up every other month, but I was not aware of any systematic review or something like that showing the superiority of pregabalin or gabapentin over what I would have considered first line, that would be duloxetine or amitriptyline. But maybe I am mistaken. Do we have solid evidence really?
Yes. So there is much evidence coming out from fibromyalgia. I think the group which studies fibromyalgia in detail is the EULAR, EULAR, which is the European League Against Rheumatism. They do a lot of work on that. Their guidelines, it has been there for quite some time, which is, they don't call the gabapentinoids as the first line. The first line is a combination, is the gabapentinoid with an SNRI is what we would like to treat. It is not one or the other, it is both together for fibromyalgia. And there is an emerging body of evidence. But having said that, there was a recent research paper published just last week, I forgot which journal I read, looking at the gabapentinoids, the pregabalin and the gabapentin. And they come up and said that, we very rarely explored the cardio risks of these drugs in the long run, because we think we can use gabapentinoids for 30 years without any problem. They came back and said that, yes, it causes obesity. pretty much, and there is a lot of sleep disturbance in people who are taking long-term gabapentinoids. So this is something we need to think about. So if you're going to start someone who with fibromyalgia who invariably has a sleep problem on a drug which we think is going to help, it might relieve the pain, but it might make their sleep problems better. So there are a lot of sort of slicing and dicing there, a lot of nuances which we need to understand. But it is the combination. It is not one drug or the other. The EULA recommendation is we should start the gabapentinoid along with an SNRI. It could be pregabalin or gabapentin. The SNRI could be duloxetine or venlafaxine, but duloxetine, I think, seems to be sort of more accepted. I don't know for what reason. But as you said, I mean, we always have to have the industry in the back of the mind before we start prescribing these medications, because we don't know where, who sponsors these studies.
And a final question, Jay. You, in your establishment, you actually have CBT, cognitive behavior therapy? Do you? You have?
Yes, sir. Yes, so we have CBT, and we have a couple of psychologists with us. They do, I mean, they all come from different schools of thoughts, actually. Psychology, I mean, CBT is a much more structured way of dealing with it. I think a few people talk about NLP, which is neuro-linguistic programming, psychodrama. There's a lot of things, but yes, we do look at the cognitive sort of dissonance or sort of thoughts which are not helpful, unhelpful thoughts, and also look at the behavior. So we do offer CBT sessions, but it's not that many people accept it. That's the biggest challenge for us, because we have a service, but the first question people ask is, I come here saying that I'm in pain and you think I am mad. So this is the challenge we face when we ask them to go and see a psychologist. So we kind of try to tell that, okay, they'll teach you some relaxation techniques, which will be much, much useful. When you combine that with your exercises and our treatment, then, you might probably get better. But yes, we do offer CBTs.
We don't have time to go on. So shall we move towards the case presentation? Dr. Rajeshri? So, Dr. Rajeshri will be presenting the patient story.
Shiva, could you please share the slides?
Yeah.
Next slide, please. So today we are going to present. Am I audible?
Yes, ma'am.
Today we are going to present the case history of a 22-year-old female who has been presenting to us for the last 6 years. She has been complaining of pain on her posterior chest wall, particularly along the spine, which is mostly localized in the interscapular area. The total duration of pain is 6 years. And the pain is found to be periodic, and it is moderate to severe in intensity, and it is described by the patient as aching in quality. And what she says is the pain is precipitated by exertion, need not be a severe exertion, sometimes while carrying out routine activities like going to school, carrying the school bag and going to school. And when present, it disturbs a patient both physically and emotionally. What she says is she is not able to carry out her daily routines in an effective manner. And it has been found that there is occasional appearance of a diffuse swelling over her trapezius, and there is a presence of trigger points on the area of pain. Next slide, please. And the comorbid status, I mean the concurrent illnesses are, she has been found to have mitral valve prolapse, and she used to be brought to hospital with history of postural hypertension quite frequently, which is marked by episodes of syncope, and which used to get corrected with administration of IV fluids. There is family history of tuberculosis, and she had one cervical adenitis, but the investigation turned out to be negative for tuberculosis, and the symptoms got subsided with antibiotics. And there is a history of accidental consumption of cleaning solution. Once they said specifically that it was accidental, we couldn't elicit or explore the history further. And other investigations like inflammatory markers and PET scan were found to be normal. And MRI once did, it revealed sacroiliitis. And vitamin D estimation, it is given as vitamin estimation, but please read it as vitamin D estimation, which was found to be low, and it got corrected. And the blood culture was found to be positive for Pseudomonas, but we couldn't find any primary focus for that. But culture became negative with treatment with amic acid. Next slide, please. And the provisional diagnosis was kept as fibromyalgia. And we had given a trial with multiple analgesics, and each trial gave her a short period of pain relief. The drugs which were given to her was NSAIDs, steroids, and baclofen. And we have tried trigger point injection, but unfortunately that was not successful, and it actually worsened this pain. And we had also done a psychiatry evaluation. We had given trial of antidepressant, but the result was, or the outcome was doubtful, and she never had the regular follow-up. Next slide. And the current medication for past 5 months, she has been on fludrocortisone 0.1 milligram once daily, and duloxetine 30 milligram once daily, and gabapentin 400 milligram once daily. And she had pain relief for past 3 months, reasonably good pain relief compared to her previous experience. And she had attended our outpatient clinic a couple of days ago, again with pain. So now we are in a dilemma how to move forward.
So in this patient, the pain is mainly in the interscapular area, not a widespread pain. So
she said the pain has been, she was experiencing pain all over the posterior chest wall, and particularly over the spine, and it is particularly localized to the interscapular area.
So for diagnosing fibromyalgia, I think the pain should be both above and below the waist, and I think Dr. Vijay will be able to, or Dr. Mary will be able to tell us.
A lot of interesting points which was mentioned by Dr. Rajshri, because it's a little bit confusing actually, because she seemed to respond to medications which you would typically use to treat fibromyalgia, whereas the tenderness or the trigger points is localized around the interscapular region. Now, if someone comes with that kind of history, particularly made worse with stool bags and stretching, then there are a couple of muscles which I would think about in the interscapular region. One is the levator scapulae, and the second one is rhomboids. Now, these are the two commonest muscles which get sprained in the interscapular region. And if at all we want to make let's call it a diagnostic injection, we put in some local anesthesia or just even a dry needling and the pain disappears. As Dr. Mary Abraham suggested earlier, we can be a little bit more specific if we're going to use it like a diagnostic. You can maybe use an ultrasound scan to do the injection or the needling, which would give us a much more pointed sort of pointers towards whether this is a fibromyalgia, or whether it's a trigger point, or just a myofascial pain syndrome. What is also interesting in this patient is the sacroiliitis, which they picked up in the MRI scan. Now, in a young patient, 22-year-old sacroiliitis, it would set a lot of alarm bells ringing in my mind, actually. I would rather have her investigated by a rheumatologist to rule out rheumatological causes, including the HLA, B27, which ought to be tested, particularly. Though it is not very common in women compared with men, the ankylosing spondylitis, but isolated sacroiliitis, that's the only positive finding in the whole sort of thing, which from a rheumatology perspective. So that is something I would think about as well, actually. So I mean, I agree with Sunil, because if it is an isolated interscapular pain, I would think more in lines of trigger points, and we should follow that up with a lot of stretching, because the injections are very, very short term only. The only thing which is going to help is the stretches and the exercises. So if we can isolate the muscle, whether it's the levator scapulae or whether the rhomboid major or minor, if we can isolate that particular muscle and we can do the injection, we can prove that our injection helps, we can follow that up with a lot of stretching exercises. There are targeted exercises we do both for levator as well as for the rhomboids, which will help in the long run. But I mean, what is throwing the whole thing off from our line of thinking is the fact that she responds to drugs which are typically used to treat neuropathic fibromyalgia, like gabapentin and duloxetine. But having said that, I think she's come back and said that she's not responding well enough. So I think I will think along, if it was my own patients, I'll think along those lines. I'll get a rheumatology referral first to see what that sacroiliitis problem is, whether it is something we should be worried about or not. And then do a targeted trigger point injection with stretching. And if nothing works, then I'll go back to scratching my head again.
Yes, madam.
I was wondering, why is fludrocortisone being given? A steroid. I couldn't figure that out. Any idea, Dr. Rajshri?
Probably she was having this hypertensive episodes that may be due to that may be help.
Yes, madam.
See, for fibromyalgia, in addition to widespread pain, they should also have symptoms of, I mean, this is generally, they should have symptoms of extreme fatigue, they should have sleep disturbances, and even cognitive changes. Normally, you know, all these things together with widespread pain, like Dr. Vijayanand said, which Dr. Sunil also mentioned, this is just localized pain. So I'm a little doubtful of the diagnosis of fibromyalgia also, because does she have the other symptoms that are commonly associated with fibromyalgia, like fatigue, non-restorative sleep, as well as cognitive changes? I think that also should be present, along with, of course, widespread pain.
She didn't have any cognitive problems because she completed her schooling and she has passed the BTech civil engineering examination.
So what would be the cause of swelling which sometimes appears in the interscapular region? Is it muscle contraction or something else?
Yeah. I mean, we have patients complaining that they can feel a swelling, and sometimes they ask someone at home to do some massage when they have these pains, and they come back and say, see, when they're in pain, I roll my finger, I can feel something running underneath. Okay, so this is what they report as swelling. It's not like if you go and look at it, it doesn't kind of look swollen or anything. It's just it's a perception. And I mean, this is my thinking that it's going to be the top bands. With the trigger point, with the myofascial pain, you have these top bands which like little frogs jumping under the skin if you run your finger, and that's what they report as swelling underneath. Actually, sometimes it might be an acute inflammation in the muscle which might present as swelling, but most of the times it is the top band which they report as swelling. So if they do report that, then your target is straightforward. If at all you're going to do some needling or injection, I think the top band is where you want to aim for.
Anybody have any comments? So I would like to ask, yeah, Dr. Sushma.
Yeah, wanted to ask
Sorry, you are not audible.
the question whether there were any interventions tried for this patient, like a suprascapular block or anything. It is very bad. Were there any interventions? Am I audible?
Yeah, now you are okay. Any interventions has been tried, like suprascapular nerve block? That was the question from Dr. Sushma.
No, you had done only trigger point injection. You have not tried only trigger. And that was a failure.
Sir, 1 minute. Let us unmute.
You hear me? Arising from that question, my question to Vijay, is there either a diagnostic or therapeutic supraclavicular nerve block indicated there? Would a diagnostic nerve block help? And if a diagnostic nerve block does help, is there a therapeutic option there by means of an intervention?
I think it's highly unlikely that a suprascapular nerve block, because the pain is typically interscapular, and the suprascapular kind of supplies more the shoulder rather than the interscapular region. So I think it is unlikely to be of much use, actually. In fact, I don't think we have, it has to be somewhat of an intercostal nerve block, or maybe even a thoracic facet joint. We can think along those lines. It's very rare to have a thoracic facet joint causing that problem, but we have seen a few patients where we do a myofascial trigger point injection, not responding, and then you start digging deeper literally and find, there's a thoracic facet joint as the source of pain. So I think those two things we can think of. But suprascapular nerve block, I think it is unlikely to be of much use in us helping arrive at a diagnosis.
Sir, could you please explain once more the cause for that occasional appearance of the swelling? I didn't
that is the taut bands, madam. In the myofascial pain, myofascial pains, MPS we call it. There is like a group of symptoms. They have pain. They have pain on latency as well. They have pain on active stretching. So it can be provoked as well as spontaneous. You have what's called the taut bands. You feel the finger around the muscle, say for instance, the interscapular pain. The commonest muscles are the levatoscapula and the rhomboids, the rhomboid major and the minor. So we run the finger across the rhomboid major, and you can feel the taut band, which is basically, it's like a fibrous muscle which kind of runs around, and that could be interpreted or explained by the patient as having a swelling. So if it is reported as a symptom, then we think along those lines, but we still have to look at it. As I said, there can be a mild sort of inflammatory process going on, and it can be a real inflammation, a real swelling. So if it is a sign, then we look at it differently. If it is a symptom which has been reported as a swelling, then we think along it as taut bands. It's TAUT, taut bands. It's like that little fibrous thing which runs in the skin. And you also have the zone of reference. You put your finger and press hard, it spreads to a certain region. For instance, if someone has sternocleidomastoid myofascial pain, you press it, and it has a typical sort of spread around the ear and the posterior thing. So every muscle closer to the attachment, it spreads actually. So you press the belly of the muscle closer to the attachments, you have the zone of reference. So that is, again, it's a pointer that it's a typical muscle pain.
So, sir, is it more in favor of myofascial pain syndrome? Because if the pain has got a zone of reference, then it's more in favor of a trigger point.
It's the same, actually. Myofascial pain is the same as, part of the myofascial pain is what you get the trigger points.
Okay.
In fibromyalgia, we get what's called the tender points, and it's more diffuse. And as Dr. Mary Abraham pointed out, it doesn't appear in isolation. Actually, you put the figure anywhere and it starts hurting you. You get it in the lateral sort of buttock area. You get it in the medial knee. You get it in the outside of your elbow. You press the sternum asteroid, it's painful. You press the neck, it is painful. So wherever you touch it is painful. Not just the interscapular region. And then it is almost always, there is a sleep disturbance, which Mary Abraham pointed out. There is also a non-restorative sleep. They feel unrefreshed every time. There might be some stiffness and swelling generally. And all these things put together it's fibromyalgia. And the age, it typically affects the middle-aged women. It's 9 out of 10 sufferers of fibromyalgia are women. So she's 22-year-old, and she's had the pain for 6 years. Now, for someone that young to get fibromyalgia, it's even more rare, actually. I'm not saying it doesn't happen. I myself have seen 1 or 2 patients, but it is much more rare.
Will she be benefited with exercise, stretching exercise?
Yes, sir. Yes, stretching will help, absolutely. But what Madam has suggested in her presentation is the pain gets worse when she stretches it. So the thing is, we need to find a way where we can relieve her pain, maybe by doing some targeted trigger point or some injections, just to get the pain down by 20, 30, 40%, which gives her the confidence to go on stretching. Because the only thing which is going to help, if we are going to move towards the direction that it is a trigger point or a myofascial pain syndrome, then that's the only thing which is going to help her in the long
Sir,
just to add to Vijay's response.
Can I ask one question?
Let sir complete.
I'm just adding on to Vijay's response to that and possibly suggesting mechanism of appearance and swelling. Everybody who sees
I want to know.
Dr. Sushma, please wait.
Dr. Sushma, I'm happy to wait if you have something. Okay, I'll go on. I think there is some misconnection and her line was not good, so maybe she was missing out on some other things that we said. Raji, I'm taking you back to the basic pain mechanism and the reflex responses to pain. Wherever there is pain, there is a reflex muscular contraction. Now, this is very common, and if we just systematically take a look at everyone in pain, trying to compare the two sides, we will find very, very commonly that whatever be the cause, whether it is joint problem or muscular problem or myofascial fibromyalgia or whatever that is, at the time of pain, that particular side will get swollen. Typically, you see it in the shoulder. The suprascapular area is swollen in some places. Now, the same person may not have the pain, that swelling later in the day. This transient swelling is fairly typical of a simple reflex muscular contraction. So, Vijay already said about actual myofascial trigger points with taut bands or nodules. But what I'm saying is, even without that, just the presence of pain can cause appearance of swelling in that area purely because those muscles are contracted there. Dr. Sushma, you had a question. I have finished.
Ask the same thing. What is the pathological difference between a tender point and a trigger point? Because we say a trigger point is a dysfunctional end plate where there's a lot of activity, a lot of excitatory signals and at the end plate. So correspondingly, what is the pathology in a tender point? How does it differ from a trigger point?
From a pathological perspective, I think you see very minimal changes in a tender point, actually. You don't see the kind of changes what you see in a trigger point in a tender point. You might see some muscle sort of atrophy and things like that, but pathologically, fibromyalgia, and as I kind of mentioned earlier, it is a complete misnomer, actually. And we call it fibromyalgia because we thought it was coming from the fibrous tissue and the muscle. The current thinking is it is a sensitized nervous system which picks up touch and pressure as pain, actually. So the problem is in the spine, it's in the brain and the spinal cord. It is not in the muscle at all. So if you're going to look for pathology in the muscle, then you're going to be very disappointed, actually. You won't find any pathology.
Yes, madam. This patient had pain relief for 3 months, and now she came back with pain again. So, is she compliant with medications? Is she taking medications regularly, or did she discontinue?
She's taking.
She is taking regularly.
This is what she said.
Okay. So, because this is one of the steps that Rajagopal sir usually says, because many patients don't take medications usually, and they come with inadequate pain relief, and we have a tendency to increase the medication, so we usually don't ask that. Yes, madam, please.
I think in this particular lady, if at all we're thinking in terms of myofascial pain syndrome, we must address the psychological aspect, because she has history of ingesting something. Is there any psychological issues also in this lady? That accidental ingestion of the cleaning solution, maybe that has to be probed. Maybe she has some psychological problem which has to be treated also. To get to have a better outcome in addition to the physical therapy and medications, maybe the psychological issues need to be addressed also, I feel. I'm sorry to go on harping on psychological thing, but I think it could have a bearing even in myofascial.
Sir, anybody have any last minute questions or comments? With that, we will end this session.
Just one thing, actually. I mean, if we kind of go looking for, it's highly likely it is going to be a myofascial trigger point. But if the injections are not helping and things, we can probably look a little bit deeper. It could be coming from the thoracic facet joints. It could be the T3, T4 sort of level. So that is something we can have it in the back of our mind. I would put it really, really in the back of our mind, because the thoracic facet joint problem is extremely rare. And for that to happen in such a young age is even more rarer. But if you're not getting solutions with our usual sort of thoughts and our treatments, then probably we have to think along those lines.
Thank you. Thank you, Dr. Vijay, Rajshri Madam, and all the others who have joined for the session. And we will meet after 2 weeks. Yeah. On 22nd of December. Thank you all.
Thank you.
Thank you, everyone.